Welcome to the Hernia Gods Podcast. This is your mere mortal host, Luke Elms. The views, thoughts, and opinions expressed on this podcast belong solely to the hosts and guests and do not necessarily reflect the official policy, position, or opinions of Orlando Health or any of our employers. And now, without further ado, let's talk hernias. All right, welcome to another episode of the Hernia Gods Podcast. This is your mere mortal host, Luke Elms. I am joined today by Mário Rui Gonçalves out of Portugal. Thank you so much for joining us.
Hi, Luke. Thank you for the invitation. It's a pleasure for me to be here.
Absolutely. Well, as we start all our episodes, I'd love to hear a little bit about who you are, where you came from, and how you got where you are today.
Yeah, I'm Portuguese. I'm a general surgeon here in Braga, in the north of Portugal, more or less 30 minutes north from Porto, a city that probably you've heard about because it's the city that will host the European Hernia Society Congress this year in 2026. To be a great hernia party. So I just want to invite everyone to come to Porto in June, so we can make it even bigger when it starts, you know. But yeah, it's I'm living in the north of Portugal. All my residency, surgical residency, has been in the north of Portugal, and then I finished up working in the hospital in my city in 2017. That's when I started working as a surgeon here. And then on 2021, I had my examination board exam, my UMS board exam as an abdominal wall surgeon. So since then, I'm mostly dedicated to abdominal wall. So also, I've been dedicated to surgical education and training, more or less all around the world, and with a lot of people training and educating a lot of colleagues from everywhere. And that's a thing that gives me a lot of pleasure and that I love, and that I feel that I can reach more patients through their hands, not only my hands, you know. So it's another part of me, parallel to the surgical activity.
Did you always know that you wanted to be in medicine?
Yeah, since I was 4 years old. It's a story that I actually in my family, I'm the second doctor. The first doctor that I know of is an uncle of mine that was a cardiologist, and he was from Lisbon, working in Lisbon. And my story with medicine started when I was 4 years old, and I went to the mountains for a family trip, and he was there, and I just fell into the river. But in the way until the river, I just passed through a lot of plants. Some of them plants that provoke you erythema and some allergies. Mm-hmm. And then he made just a mix of other plants and some kind of things that he put on my skin. And from that moment, I thought I knew that I want to be able to cure people and treat people in that way. But then during medical school, I saw that I really loved cardiology. Not because my uncle, but because of research and all of a lot of activities that I did in medical school, in the cardiology department in my university. And then when I did my first year of residency, that we call Ano Comum, is like a general year in Portugal, I just got contact with surgery, and that was a love on the first sight, you know. So from that moment, I just wanted to do surgery.
And is your pathway into medical school, do you still do a standard like college undergrad first, or is it like a combined program after high school?
Yeah, we have high school, what I suppose it's the same. It's like the 10th, 11th, and 12th year of education that we have. That's
Mm-hmm.
high school, and then you go to medical school. So, Faculty of Medicine.
Mm-hmm.
In that Faculty of Medicine, you just are a medical student for 6 years. And after those 6 years, you get into general residency 1 year, and then 6 years of general surgery residency.
And does general surgery residency require any research over there during that 6 year period?
No, I mean you can do it if you want. So it's not necessary. At least when I did my medical school, right? But I don't know if it's different now. But at that moment, you didn't have to do that. You just had to study to pass the exams and get the degree. I always like teaching and doing some research. So I started to collaborate with the medical department and the cardiology department in the university, and started to collaborate on their research projects. And that was the how it started. This in interest in research that lead to my PhD and all of these things.
And did you do have a PhD? You ended up going back and getting the PhD as well?
Yeah, I just finished it. It's about training in surgery. So
Oh,
it's
wow.
it's called training in minimal invasive surgery. It's a new framework for the national training program, and it started in at the end of 2021, taking as a sum of everything that I was doing at that time. So I started. I can talk to you about the First Touch project. It's a well. Let's go back to 12, 13.
Mm-hmm.
I think that's the best way to start this conversation and to explain you a little bit of it. Uh, so I started to see that laparoscopy was going to be. I didn't know at that time it was going to be a standard approach for some procedures, but I just understood that minimal invasive surgery was the future,
Mm-hmm.
and it has a lot of advantages for patients. So I wanted to have practice on laparoscopic surgery, and creating opportunities to my colleagues in my residency program to have contact with laparoscopy and training. I would say that if I had to describe myself, I would say I'm an opportunity maker. So I like to create opportunities to give. So I'm a giving person.
Mm-hmm.
So everything that I do has created opportunities for a lot of people, because I believe that people have talent, people have capacity to do things, but sometimes opportunities are not coming. Uh, and if we have to leave a mark here, is just create opportunities for others to shine and bright. So when I was a resident in my first or second year of residency, I wanted to create an introduction to laparoscopy course using a box. So
Mm-hmm.
I went to IKEA, this North European
Mm-hmm.
brand for furniture, and I just bought this plastic box, transparent plastic box. We did some holes for as the ports.
Mm-hmm.
Then with the webcam and some exercises that I did with my father at home with wood and some screws. So we had these basic exercises. So we started to do the C-Lab. It was the curso de introdução to laparoscopy. So introduction laparoscopy course.
Mm-hmm.
So the main goal was to create an opportunity for people to have their own tool for practicing. At the end of the course, so we did 3 courses like that for 16, 32, 48 people, residents at that time. And at the end of the course, they told me, oh, we have a box, but we don't have instruments. So it would be interesting to have instruments. And yeah, on the second course, we got sponsorship from a company that gave us instruments for the course, so they could take the box and the instruments to keep practicing at home.
Mm-hmm.
At the end of the second course, they told me, okay, but now we need needle holders because without that we can do laparoscopic suture. And then I got away to get needle holders from China, import some to have on the third course. So people would have laparoscopic needle holders to do laparoscopic suture and keep practicing at home. Well, it went well, but then it was my end, the end of my residency program. So in 2016, 15 and 16, I've been a little bit less active. But then when I finished in 2017, I felt like I had to do it again to make it better and keep this project live. So and maybe all of these things come in my DNA because my mother was a teacher and my father was an entrepreneur. So probably mixing all of these things, it got me the teaching part and the educational part and then the entrepreneurship part all mixed together. It came up as First Touch. So First Touch was based in my observation of some problems that I identified, like missing opportunities for training. We didn't have tools for practicing at home or and continuously, and I also didn't know all of my colleagues from my year of residence. So the solution for me was to, okay, we have to create the same box. We have to create a course, a national level course, when all the residents can come and meet each other at the beginning of residency, and that course could have a curriculum based on simulation to prepare the residents to start residency. So the best moment for that was some time before the beginning of residency. So it is in December every year. Our residency starts at the 1st of January each year. So the course is in December. It's for all the residents in the country, but the new residents, not the first year, second year, if they want to come, they can. So if you only have one first touch, your first touch. So when you start residency, you have your first touch. You can come on the next year or the next year. So you have to come because it's your class. It's like your group.
Right.
Because it's not only simulation; it's for them to get in contact with each other. So they come for 3 days in Braga. They are 24 hours with us. So hotel is included, all the meals, everything. So when they arrive, they start with us and they leave 3 days after they arrive. But the thing is that I normally say that they come as anonymous and they leave as friends from Brian. So that's First Touch, and that's how it started. Since then, they asked me about models for practicing on the first trainer. So that's when I started to do the silicone models, like laparoscopic suture pad. And then it started with my PhD, the appendectomy, cholecystectomy, and so on.
When you were going through your training, is it something that you felt like you were missing opportunities for education because those didn't exist, and that's what prompted you to kind of pursue that avenue? Or was it something that once you got out and started trying to educate others that you realized that, hey, if I had these models or if I had these more standardized approaches, that this would be beneficial?
Yeah, both of things, from my own experience, and also it has been developed with posterior observation. So first of all, I wanted to create opportunities because there was no opportunity on that. And then I started to see that pigs and cadavers are really high cost, and you don't have much opportunity to practice on pigs or cadavers. You can go once or twice in your life to a simulation center to have a pig lab or a cadaver lab, but you can't do it repeatedly. So we had to make it low cost, low logistics. So even better if you don't have to go to a simulation center to do the training. If the training can come to you, That would be the perfect solution. So of course, I don't mean with this that we don't need pigs or cadavers for practicing. Of course, we do, but it's not possible to have a lot of opportunities if you just think about those high cost simulations. So I believe that, and one of my quotes is transfer the learning curve from the patient to the lab. So, and to do that, you need to practice a lot.
Right.
So you just have that opportunity of practicing a lot if it's low cost and low logistics, and you almost can do it at home or in your hospital. One of the good things about First Touch is that indirectly, what we achieved is that, and I forgot to tell you that First Touch as another great feature is that we give one laparoscopic simulator to every resident when they come to the course. So it's free for them. So they can continue practicing at home. And giving opportunities to them to have that a little bit like it was in 2013 when we started the introduction to laparoscopic course, but it's not a box. It's a really good simulator, validated everywhere. So they have it to take home and keep practicing. And I was, yeah, okay. So regarding that, indirectly, what we could achieve is that we gave hospitals simulators. Because if people have their own simulator and the chief of the department just says, okay, so next Monday, everyone will bring their own simulator to the hospital and we can do a simulation lab here. So for the hospital, it's €0, no investment. They just need a space, a room. It can be a meeting room. And people have their own instruments, their own needle holder, the simulator, the models, everything. So they just bring them to the hospital, and the chief or the coordinator or the resident director, residency program director can create a curriculum and just do it. So indirectly, we gave national hospitals some training tools for education.
When you're going through such an innovative process, obviously starting with an IKEA box in your garage all the way to now you have kind of a standardized national model for laparoscopic training. It sounds like you've worked your way through that, and through the process of the innovation, you've identified barriers and have worked to kind of break those barriers down to where it's more accessible to everyone. And in the process, also created more of a community amongst the surgical trainees in your country, which is obviously also very, very positive. Is there something when you're in that process? Is it that when you started and you're in your garage and you're drilling the holes in the IKEA box, is it something where you're dreaming big and you're thinking one day maybe this could be something that is like a national program? Or is it something where you just kind of continue to push and push the envelope and eventually you just say, let's just see how far this can go?
Yeah, I would say that both things are true. I when I started, I developed this 10 years project. So the Training for All project is a 10-year project. So it started in 2017 and it's planned to end at 2027. So in 2 years. The thing is that a lot of things have been added to the project. The main objective of the program, so the mission and the vision was to create opportunities for every resident to have their own tools and keep practicing and keep acquiring technical skills at home, because I saw that training opportunities would decrease along the time because more residents are getting into residency. A lot of senior surgeons are going out of the public system, so less opportunities for learning from them. A lot of pressure and overload for everyone, and these regulatory laws and the time, all of these things at that time made sense to me to think about, we have to do this project, and then we have to have more models, create some courses from that courses, came up the training program. From the training program, it comes a lot of things that I have planned into the next 2 years and more. But I can advance it to you. Is like artificial intelligence for assessment of skills,
Mm-hmm.
how to integrate this learning curve from the patient to the lab, and then return it the results from the lab to the patient.
Mm-hmm.
So assess all of that, study out, and evaluate all of those transferring situations. Yeah, I would say that it was planned. So I had this idea, this big idea, this overview, but then a lot of things have come up. For example, in 2020 with COVID, and that was one thing that I didn't have initially, is labschool.com. It's an online school that I had to create in 2020 and invest on that, because otherwise with COVID, first touch just had to end,
Mm-hmm.
So we couldn't have, because first touch lives from the contact in between people. So
Mm-hmm.
they interact, they know each other, they hug, they everything, So we have social part on the course, we have team building activities, we have the all the dinners and lunches and all of the things, the social part, and then we have also a show that we go in one of the nights to get this cultural
Mm-hmm.
part on first touch. So it's a really interesting activity, and I would love, and I get this opportunity to invite you and bring you as faculty for next year, in this year in December. So I think it's 14 to 16 of December. So we will manage a way to bring you.
I love that.
And by the way, any tackler can come also. So
Yeah.
yeah, we can have you both as faculty for the course in December. You're my invitees, okay?
Oh well, I would love to accept that. Yeah, if you bring both Haney and I, Haney can be the example of what to do, and then I can show what it's not supposed to look like. We could have the
Okay.
both ends of the spectrum, because I'll tell you, there are times you were talking about like about taking it from artificial intelligence to map that, and there are times when I'm teaching my residents that I get through the case and I go and I like I am always ruminating and rehashing every single move and criticizing myself for the things that didn't look good or whatever. And there are times you get done and you go, yeah, they saw me complete a case, but that was definitely not the most efficiency of movement. Or, get done with the case and you think, man, I just made that look a lot harder than it really was. But, so it's but I would be honored to come and help. One thing that when you were talking, it's just something that came to me is you really have brought kind of an entrepreneurial mindset, and but it's also paired with an obvious passion for education. And do you think that with the fact that your mother was an educator and your father was an entrepreneur, do you think that was just a natural progression of the environment that you grew up in?
Yeah, probably. Yeah, because when I discuss at home, yeah, I just get to my parents' home and in the weekends, and I say, oh, I'm thinking about a new course for this and for that, and I need a mom. So I'm thinking out loud,
Hmm.
and I get these inputs from my mother. Oh, you should do this or that, and then my father comes and, oh yes, I will try to help you developing a model on that. No, I have to I don't know if I can say to break him down. And okay, so you have to stop. Let me think about, and when
Right.
I have a model idea, we can talk about it. Because it's interesting. My father was one of that person that just faints when he saw blood,
Hmm. Yeah.
But right now he understands about procedures. He understands
Yeah.
about bariatric surgery,
Yeah.
everything. So he just sees. I have my videos, and I just tell him, okay, give me an idea of this because I want to do this. Yeah, this is my procedure, and I just put a hiatal hernia, for example. So
Hmm.
this is my procedure. So you just take a look at it and just tell me if it's enough to do an esophagus and a crura, or if we should do a stomach to
Right.
get more engaged into the simulation. And then we discuss, and it's very interesting.
Yeah. There's it's there's there are obviously models here, and it helps with the movement and understanding, the little intricacies of even laparoscopic suturing, the rolling of the wrist and the way that the interplay. But there's definitely there's definitely still a learning curve when you get into human tissue, and and then the pressure of also working on an actual person, and that's hard to replicate in a model. Do you feel that the models are gradually, or even not so gradually, but lunging forward in their ability to replicate true human tissue and get pretty darn close to the real thing?
Yeah, I think that if I was only an entrepreneur or an engineer that wanted to create a simulation company, the models wouldn't be so good as they are. I think that getting this education, entrepreneurship, and in the middle, a surgeon made me see how to create really good models, not only from the aspect as you see them, they're beautiful and very colorful and they feel good, but also from an education point of view. So the models are created. When I design a model, I just think about what are the learning objectives, and that was one of my papers in my PhD, is to think about what are the learning objectives for this curriculum. What I mean is, probably if you want to learn anatomy, and I can give you these two examples because they are the extremes, is the medical student on one side and the experienced surgeon on the other side. So these are extreme, right? But the cadaver can be the best model for each of them. This regard, they are in opposite positions. Because if you want to learn human anatomy for a medical student, the cadaver is the best. But if you want to learn surgical anatomy for an experienced surgeon,
Yes,
the cadaver is also the best model. But maybe so it doesn't mean that the high cost model is for experienced people and the low cost is for inexperienced people. It doesn't make any sense for me.
right.
It has to do with learning objectives. So I divided the current curriculum design circle, starting from needs, going to methodologies, implementation, assessment, and then returning again on designing the curriculum. And I updated that circle with the STP approach. And the STP is like skill, task, and procedure. So to decide which is the best model for your curriculum, you have to decide if it's a skill, a task, or a procedure that you want
Right.
to the learner to understand and learn, right?
Mm-hmm.
So if we're talking about, for example, like doing a suture, you can have, it's a skill. So anyone can understand how to do a suture and a knot, because it's not, you don't have to be a surgeon to know that, because there's no anatomy, there's no physiology, there's no specific knowledge to understand that skill. You just practice because you see someone doing it. They teach you how to do it, and it's a manual skill that anyone can do, right? So that's a skill. If you go to a suture of an incision, you just start to have some knowledge on the skin. Where are you doing the suture? If it's on the face, if it's on the neck, if it's on the back or the arm, if it's an incision from a surgery, or if it's an incision from an emergency or a trauma. So the incision or the wound can be different. So the suture has some specifications that may be different. So you start to have the need to know, to have some knowledge to understand how to do the best suture there. So you have a lot of skills to get into that task. And then you can have a full procedure that has suture on it. So it's a procedural part and not skill or task. So based on that, just to get into the point, so if you have skill, task, and procedure, then you can adapt the best model. If you are talking about suturing for a skill, you can have a small piece of silicone just for, or a foam or whatever, just for you to practice. If you need an incision for a task. So probably you should have a silicone or a piece of meat or from chicken or orange or a banana or whatever, so that can give you some layers or whatever. But if you need a procedure, then you can go to the pig, to the cadaver, to a silicon model, to whatever. But that makes you understand and have the need to use some knowledge on the anatomy of the stomach or the stomach wall or whatever, So just to get into the point, I think that the models are very important for practicing because they give you more opportunities, and that's the main thing. I don't want to make, for example, my models don't bleed and they don't have nerves, for example, and
Right.
they just don't. You can't use energy on the models because from my observation and my study on the model, I think that it's not necessary for them to bleed because you're not teaching them how to control bleeding. We can have a model with some vessels. If you want to do a trauma course or a control bleeding course, whatever the learning objective that you have from a bleeding point of view, so you can create a model for that. In my, for example, TAPP model, you just have elementary landmarks, anatomical landmarks, and structures as the peritoneum that you have to open. Then a new silicone that is sticky that makes the space. It's a virtual space. Then you can dissect everything to get into the space to put the mesh and then close the peritoneum. But on the other side, you have some structural, anatomical structures and landmarks that you understand what is the pubic bone, what is the inguinal ligament, the artery, the vas deferens, and all of those things. So it's not just a silicone for you to put a mesh inside a peritoneum, but it's actually an inguinal TAPP model, very easy to do and to understand the movements that you need to know and master on an inguinal TAPP. So you don't need energy because I don't want you to just use and cut, okay? And it doesn't bleed because I don't want you to control bleeding on the inguinal TAPP repair. You understand?
Yes. Yeah.
So when someone tells me, oh, but it could be bleeding and it could be this or that, and I say, from an educational point of view, there's no need for that. I don't want to make the model more complex and more costly because it will decrease opportunity for you to buy it or for a company to support you and your training. So I try to do the most basic models with the less features needed for the learning objectives that we have. And
I think
that's the goal.
Yeah, something I've noticed both in myself and in the trainees that come through is an underestimation of the translation of skills. And so when you're doing the modeling, maybe with a lab skills trainer, and you're cutting a circle out of a piece of paper or something, and you're sitting there going, "This is annoying," and I'm going to learn how to do this task, and you move on. And there is a disconnect at times between how that translates to real world. And you talk about the the models that don't bleed. Well, it's really hard to learn in a model that's bleeding when if you get into some bleeding, all of a sudden the planes are obscured. That's the next level of learning. The next level of learning is beyond, from my opinion, is beyond knowing how to get through the case, knowing where things should be, but then knowing how to do it in a way that you don't make it much harder on yourself. And so, in my OR, when I'm teaching, I'm annoyingly concerned with hemostasis for a couple of reasons. One is just good surgical technique, but two, like for instance, in big inguinal-scrotal hernias, I'm doing robotically that I do fairly frequently. A little bit of blood in those planes, and all of a sudden that case is way harder. And but if you don't know what you're looking at to start with, even when there's not blood, that case is almost impossible. And so there's a lot of that. But when we're doing, my partner and I, we really harp on the residents for cases that you can get through the case doing a certain surgical technique, but the skills if you do it with good technical skills on the smaller cases, the translation to the larger cases is much easier. So, for instance, even doing things like taking down the peritoneal lining, medially and laterally on a cholecystectomy, if we're doing it robotically, that seems like a throwaway portion of the case. And so I watch some residents, grab it and just bovie up the side of it and everything. Okay, yeah, you can accomplish the case that way. But if you're really trying to take the time and dissect off that layer, elegantly, then when you're down dissecting, a layer off of the vas, or you're dissecting the medial portion of an inguinal hernia where you're down staring at the iliac vein and things like that, then all of a sudden, it's not the first time you've ever tried to dissect, carefully. And I think that sometimes I don't do a good enough job of articulating to the residents why we're being so hard on them on the techniques on things where they're otherwise going, that level of, you're adding 10 minutes to a gallbladder because you're harping on me about this stuff. Whereas I'm not thinking about the gallbladder. I'm thinking about every other case that they're going to do and the translatable skills. And so I think that it's funny because I routinely will tell the chief residents I work with, like, I'm going to be annoyingly critical of every move you make. Because if you are sewing closed the peritoneal flap from a robotic tap inguinal hernia repair, there's a big difference between, throwing a baseball suture that gets the flap closed versus throwing it and making sure you're turning your wrist and not pulling the end of the swedge of the needle laterally or medially if you're sewing there and tearing little holes in the peritoneal lining, because, the next time you go to do a bowel anastomosis, that tissue handling is a problem. And sometimes people, obviously people are more perceptive to that than others, but I don't think I probably do a good enough job of articulating kind of the way, the thought-wise process and the stepwise process that you've just articulated on the learning and the very specific learning steps that are necessary to gain proficiency. And so it's really interesting to hear you talk about that. When you went through and you decided to get your PhD, it's in like surgical education basically, or modeling and things like that. Was that something that you were already deep into this idea before you decided to do that, or was a PhD always on the horizon for you, and that's just what you landed on because that was your interest?
No, I had the idea of, as you see, it was like growing every time. So a lot of things were coming into the project, although I had this vision at the beginning of it, but then a lot of things came to the project. So I wanted to do something, whether it was officially as a PhD or not. For me, it was necessary to create these models for practicing, in my own box. But at the same time, I felt that I could do it more officially, and if I'm developing this and I have to assess, because I was doing all the assess, although it was empiric, I was creating things and assessing those things to see if there was a need to upgrade it and make it better or different, So why not doing a PhD on this and validate everything, do the studies, educate myself in statistics and methodologies and all of the things. So it was natural to make it a PhD from it.
Have you, as surgeons, we all have our own complications. And you have seems like a very logical stepwise process in which you analyze an issue and then go through the different steps of that. Do you feel like your analytical thinking that you've been able to apply to those steps that you've gone through with other aspects of your career, is that the same way you approach a complication, or is there a level of like the personal hit, to a personal level that kind of is different when you're thinking about those?
No, I think it's more or less the same. Of course, we are always learning, and the experience comes from everything that happens in our life, right? So and the interactions that we have with other people from other hospitals, and I always wanted to and did my best to have a lot of experiences with different people. So starting with colleagues in Europe, in the US, in India, in a lot of countries and places in the world. I always wanted to learn from others and also the cultures. Um, I think that this kind of thinking is something that it's me. I just I observe a lot. I look at things in a way that for me is not just looking. I observe, so I try to see problems and try to find solutions to problems. So when I see that I'm not doing something well during a surgery, I just see my videos, I review it, and as you were saying previously, is I could do this much easier if I went from this side or the other side, or if I just move my left hand, or if I why did I went from medial to lateral instead of doing the dissection on a um, continuous line. I don't know, but so it's interesting to see our videos, and I would say that sometimes I can look at the video and I know if it's me or if it's my resident, or any other colleague. I can say no, this is not me. I can assure you that this movement is not mine.
Right.
So yeah, I think it's I think the same way, and most of all, for example, in my models, I always wanted to have the possibility to teach residents how to move the left hand, because they actually do everything with the right hand, and they don't understand that the left hand is giving 50 or more percent of the procedure.
Yeah.
And I actually think that when you see a video on a congress and you see, this surgeon makes it so easy, I can do that because he just does it super quick and super easy. Wow, this guy is incredible. And they just don't look at the left hand, and the left hand is doing everything. It's pulling, it's pushing, it's traction and counter traction, and the right hand just does all the small steps that the left hand can help you. And of course, we have on open surgery, we had the assistant doing that for us, giving us a field, and you felt like, it's easy to operate with Dr. X, and it's a nightmare to operate with Dr. Z, because Dr. X doesn't put the hands in front of you and just gives you field so you can see everything and you can dissect, and he helps you doing a lot of experience, and he helps you doing the surgery, and you like to operate with him. And the other one is just putting the hands and moving. And so in laparoscopy, you have the assistant with the camera that sometimes is looking to the other side, or and you're trying to do some movements, you see. I'm sure you know that because we all have been there. And it's a learning process for the residents, of course. So camera is very important for them to understand. Sometimes you are focused on one thing and they just focus on another thing. It's not they want to go with the camera to other place. It's just because they are focusing on something, and you have to, just focus. I'm here. Oh yeah, okay. Sorry, but yeah, the left hand is very important, and if we are our own assistants creating the field for us to dissect and do the movements, because if we look at all the surgical procedures, it's basically the same. It's like cutting, dissecting, traction, contraction, and knotting, suture and knotting. And you can do that for a vessel, for the gallbladder, for the stomach, for the peritoneum, whatever. But you need to have anatomy on that. You need to have pathology on that. If you have a lesion or a cancer or everything, it's infiltrated, and you have to dissect and see other planes. So if you just have and separate those parts of, okay, I'm good on the skills, I can do this technically, and now I manage anatomy and surgical planes, and I manage the pathology, so I understand the patient as a whole. And I think that abdominal wall is it's an example of that, because you have the skills, okay? But if you don't know anatomy, or if you don't know the surgical planes, it can be a nightmare, and you can end up without doing what is necessary for the patient, because sometimes you don't have fascia, sometimes you don't have muscle, sometimes you don't have peritoneum. So you have to understand that, and so it's very interesting, and I feel in love with the abdominal wall since a long time now, and always being amazed with these new procedures that are coming out in the last years. So I think that we are living a really good era on abdominal wall. Yeah, with a lot of people actually writing the books and writing the procedures right now. It's not something that happened 50 or 100 years ago. It's happening now. So it's very interesting.
Yeah, going back to your talk about the left hand, I think that it's funny because I will harp on people that the left hand is really the hand doing the case if they're a right-handed surgeon, even if they're a left-handed surgeon, because we frankly, try to force left-handed surgeons into a right-handed surgeon's operative technique in many cases, unfortunately. But the left hand is always doing the retraction, and I will constantly harp on my residents about, when they're grabbing a peritoneal flap off of the retroperitoneum to dissect back to get mesh placement, they'll be pulling it directly down the line of sight, and you can't see anything to dissect and how to move that. But then like the next step is always that the left hand, even if you get the retraction in the right direction, it's not static. And the more you release, the left hand has to continue to move with you. And whenever I came out of training, I would come out and start doing little things. I remember one time I was literally putting in a port, and I'm up on the chest wall, and I'm like, why is this so hard? And I realized that I had not set up any kind of retraction in any like effective way. And then you come to this fact, you're like, wait a minute, I went through that whole training my last 2 years thinking that I was doing the case, and the attending was doing the case with the retraction the whole time. And I was just like a Bovie jockey. And then you start to come to that realization that, oh man, there's so much that's left to learn even after graduating residency. So there are times now that I'll intentionally, not set up the retraction and make them, tell me where to retract and what I need to change to make it better. Because like you said, you're always only as good as your assistant in many cases. It's like you want to have a button that just repeats the saying every about 10 seconds, that when someone's holding the laparoscopic camera, it's like buttons up. No, buttons up. But you're sitting there like turning your head, and pretty soon you're like, why am I'm operating like upside down, because they have the buttons like facing the wrong direction. But then the most humbling is when I'm used to doing the case and then I'm running the camera and I'm like, buttons up, and I look down and it's in my hand and I'm like, oh geez, sorry. I'm not immune either. But there's so many things about the skills of the surgery that matter. But one of the things that I have found so incredibly important in my practice was consistently reviewing the imaging before and even after the case, because the prediction of where I'm going to get into trouble and the concerns about and knowing my bailout maneuvers, or really predicting what bailout maneuvers I may need to utilize if I'm looking at a scan and I go, okay, well, this is a lower midline incisional hernia from a C-section. Well, there's a pretty good chance you're going to stick a camera in and be staring directly at the rectus muscles. And so, you have to know like what to do in those cases, and really predicting ahead of time. That's when I feel like I've been able to get through some of the more difficult cases with a little bit less stress. But going back, one other thing I wanted to touch on, because you had so many good points. Whenever you were talking about going back and reviewing your film, one of the pitfalls that I fall into is when I go back now, especially we use the DV5 robot now, so it's all recorded. And so that has been a big change for me, watching my own film. But I have noticed that when I go back and watch film, many times it's in cases where maybe something didn't turn out correctly, or I feel like the case didn't go that smoothly. And so when I'm watching that, there's a level of kind of angst or anxiety around watching something that didn't go well. And so then sometimes it gets to the point where you're watching the film and I'm thinking I'm probably not taking as much from this as I could, because I'm also kind of dealing with the personal aspect of my judgment of my performance. So recently I've gone back and looked at some cases that I thought went well. And I have found so many learning points whenever the pressure is off, and I'm not just like sitting there dreading watching the moment that I know something failed in the future in retrospect or something. So I do think that there's a lot of benefit to reviewing that game film, because in all the other high level, performance sports, for instance, watching game film is something that all these athletes and high level, they credit a lot of their success to that. But I think that surgeons in general, we're at least a lot of the average surgeons in the community, that's not something that they ever really do.
Yeah, it's true. I think it's very important that the bad thing about it is that when you think that you have a good video to review, and then when you go back and put the USB drive on the video, you open the video, and there's a small amount of blood covering the image.
Yeah.
All during the whole procedure. Oh, it was so good, a great suture that I did,
Yep.
and it's not focused, or
Right.
there is something happening there. But it's very important. I think that video reviewing is very important, and even for residents education, for to put them some videos playing and ask them, stop the image, and what do you do here? What is the anatomy? And that was a great example that Conrad Ballister, I saw him doing in his hospital at the meeting that they had with residents and all the staff in the morning, and stopping the anatomy and putting some images and asking, well, what is this? Where's the head? Where's the foot of the patient? What are we looking at? What do you do in this situation? And that is a very, very, very good learning situation. But it takes us to a problem, is that I would say when you talk about athletes and football clubs and whatever, the basketball teams and whatever, is that they are more professional than us. And this hasn't to do with surgeons themselves, because we are comparable to the NBA players, I would say, but the surrounding factors around the surgeon, those are not professional.
No, they're not.
And what I mean is that the team manager, the coach, everyone is as professional as the player, because they have one goal, that is having the best outcome.
Right.
And unfortunately, sometimes or many times, what I feel is that I'm the only one trying to have the best outcome. Because the hospital doesn't care. It's just a number. It's just a patient. It's just a hernia. They don't care. They just want to follow the schedule and have the program and numbers and money. And I feel like I'm the only one, and that's a problem, because if we try to say that we need protected time for training and protected time for reviewing my cases and protected time to see videos and protected time to go to congresses, because I want to be better for the outcome, to be more professional, no one understands. Just you don't want to work. You just want to operate, and then to have hours without doing nothing. No, it's not doing nothing. It's learning. It's like reviewing everything, getting that into our head, so in the next case we can be better. So at the end, we just don't have only better surgical outcomes, but better time, efficiency, money outcomes on the procedures. And unfortunately, not everyone understands that part of surgery.
Yeah, there are many cases, at least here in the United States, and I'm not speaking directly about my institution. I'm just speaking in generalities. But there are many cases where the way that surgeons are compensated, the way the system is set up, it de-incentivizes that type of work, except in certain situations. because many times a lot of people are on RVU based models here, where they're based on productivity, or they at least have productivity goals that you're trying to hit, and that those types of stressors in a practice can really impact your ability to teach, your ability to do the professional development. I mean, we get continuing medical education. Many places have continuing medical education, stipends that they will give us or time. But, if you're looking at, a few days a year, well, really continuous medical education, is a continuous process, not a process that you go to a conference once a year and say, well, I'm educated, and go back and do the same thing you were doing before. But there's no incentive to really review that beyond the quality metrics, right? But I think that in many cases, there is a difference between doing a good surgery that will not get you in trouble for poor quality and doing the best surgery that you're capable of doing, or the best surgery that the patient's capable of receiving. And so I think that, it's a problem that is so large and so ubiquitous across the whole system. I don't think that this is one thing that there's not one easy solution, and I don't claim to have that solution. But I do think that in my practice, there are definitely times when, whether it be, I don't necessarily even think it's institutional as much as it's my own, but I feel like an obligation to, hey, this patient's, waiting a month or two to get their surgery with me. I need to fit more cases into a day so that these people don't have to wait as long, because I feel responsible for making sure that they have the best outcome as soon as possible. And so then when I'm in a situation and I know that realistically teaching a resident is going to take me, 30 minutes longer to do this case, well, then all of a sudden you start to do the math and you say, well, realistically over the course of a day, you've lost a case. And beyond the financial implications of that, to say that those don't ever play a role is probably naive. But beyond those implications, it's many times we're not incentivized to pass that knowledge along in a acceptable way. It's this is how you get through the case. Yep, that's good. That's going to be just fine. Hey, good job. Next case, right? It's not the no, stop. You need to be rolling your wrist more on this throw. And when you pull the suture through, you need to pull it through at this angle instead of this angle. You're disrupting tissue that doesn't need to be disrupted. Things like that take time. And I think the modeling you're talking about beforehand can go a long way, right, to help to make sure that those techniques hopefully are maximized outside of the setting of the operative theater whenever you can start to really progress your skills in a real world setting, but your skills have already progressed so far via modeling and AI and all the other technologies coming forward that it allows that. But really from a system standpoint, the sitting down to review your videos, sitting down to create a curriculum for the residents you might be teaching, or update yourself on reading a bunch of primary literature, because the amount of literature coming out now is extensive, and those types of activities, many times the reality is that those fall into your personal time, and that time is necessary, in my case at least, for me to reconnect with my family, to do the things that require me to be the best version of myself, right? If the NBA, for instance, had a situation where they were making their NBA players play every single day, they had a game every single day, the outcomes of their season would be dramatically different, right? They wouldn't have time for the rest and recovery. They wouldn't have time for the studying of the game film that they can help make improvements, practicing as a team, all the things that make those NBA teams function well. Those things are built into the schedule of their life, whereas it's not necessarily for a surgeon. And beyond that, they have support systems around them that are much more dramatic than they are for the surgeon, right? All the way down to the physical aspect. They have physical trainers, they have therapists, they have sports psychologists that work with them, they have nutritional advisors, all these things that, because they are treated as the product of their game, and the game is the purpose and the game is their mission, but they are the product. And I view surgeons the same way. And so activities where we have a chance to connect and bring fulfillment and bring this sense of community, I think that generates benefit that eventually, if it's done well, translates to our patients. And so I agree 100% that there's a definite problem with knowing probably what could make us better as a surgical community versus the outside influences and the problems that can sometimes make it feel like there are competing interests that sometimes make it harder to do what we think might be necessary to get the best out of ourselves and for our patients.
Yeah, absolutely. And I think that the problem is that the system doesn't cover us. And what I mean with this is that if you think at aviation, you have the pilots, and probably if the companies weren't, if the companies didn't care about the outcomes, I mean, that the plane doesn't fall, probably the pilots would have the same problem as surgeons have. And what I mean is that, and I use normally a lot of people compare pilots and surgeons. That's a normal comparison, right? But I normally go a little bit beyond that, because I would say that and I normally use this as the last slide of some of my presentations, is that the biggest difference in between a pilot and a surgeon for me is that the pilot can't talk about his complications, because if he has a complication, he's done, And as a surgeon, we always can talk about our complications, because we don't, of course, we get bad and mentally frustrated and worried about the patient and whatever, and sad about it, the complications, but the complication is on the patient, not on us. When in the Spanish Congress, I made all the people learn on the auditorium, because I used an example. Imagine yourself leaving the OR with the complication, and then you're going home and you have dinner with your family, your kids, your wife, and you're totally fine. And on a single moment, on an instant, you have, oh, so I have so many pain here because the patient is having that same pain. Sure. So as the pilot, if the passenger falls on the plane, the pilot falls on the plane. So he actually has the same consequence as the passenger, right? But we don't have the same consequences as the patient. So maybe we are a little bit selfish and maybe opportunistic, because we are not practicing more and reviewing more videos and whatever, because we are not suffering the same. If we had the same complications as the patient, like bleeding, pain, whatever, probably we would give more attention and make the system mandatory to have more practice, more training, more videos, and dedicated time for all of that thing, Mm-hmm. So that's a little bit different. The biggest difference with pilots, but I don't know how to do that. I think it has to be the whole system to understand that and to give. No, we have to give dedicated and protected time to surgeons to do this, because it's important. Mm-hmm. Residents should have more time to learn and to practice and to review videos and to have time to think about things and integrate all the knowledge that they are having. It's a full amount of things that they're having at the same time. So, yeah, I don't know how it can be done, but at least if we have more opportunities for them to practice, mm-hmm. I think that's a small step, a small piece of water in the ocean. But yeah, maybe it can have very good results in the future.
Yeah, I think there's, I think obviously this is such a big topic that probably is going to take a series of steps to just kind of chip away at some of the benefits that you might be able to gain from a change in the overall system. But one thing I hear frequently in some of my roles, there's sometimes a perception, and I totally understand what you're saying about the fact that there are that there's a little bit of a disconnect between what the patient is experiencing and what the surgeon's experiencing. But I sometimes hear kind of the opposite, where surgeons are painted as people that don't care. And what I will say is, from my experience in talking with surgeons, I would think that overwhelmingly people do care. I'm not saying that there aren't people out there that may, be a little bit more flippant. I'm sure, again, I'll say again, surgeons are a cross section of society. And so there are people throughout society that have different levels of ownership and things, and surgeons are no different. But the overwhelming majority, I think, really do care. I think that many surgeons express that in different ways. Many surgeons experience that in different ways. And I think from the outside, many people will assume that surgeons don't care, but they're not the ones, they're not in the surgeon's head at 2:00 in the morning, the next morning, when they're worried about it. Because one of the issues we have as surgeons when we are experiencing complications is that, as the leader of the team, and as the person that the patient is entrusting with their care, there is a pressure and a need for us to exude confidence. And there's a pressure and a need for us to be able to move on to the next rep, because I may have a case that goes poorly, and I may have 3 more cases that day. And I may be getting ready to do 3 more of the exact same case. And after I go and get through the case, and hopefully everything is okay, and I go talk to the family, but there's a physiologic and a mental toll that takes on me. You have to, snap your fingers and get back in the game and go talk to the next person and be at your peak level performance again. We don't get to say, hey, that was a really rough day. I messed up this spreadsheet, or I had a poor presentation at my work. You know what? I'm going to take the rest of the day and go regroup, and then I'll be back to Like, that's just not a reality for many surgeons. No. I was on a trip with my family, and we were down actually in the hot tub, and in the hot tub was a group of pilots that pilot for one of the large airlines over here, and they were talking about the safety situation that they have. It's been recently that they, in their I don't know how recent, but that they have a system where at any point the pilot can say, hey, I don't feel like I'm safe. And there are no questions asked. They're relieved of their duty and replaced with another pilot. And we are not necessarily afforded that same level of grace. And in fact, if you have a surgeon that comes out and says, I don't feel good today, that sometimes is almost viewed as a weakness. For instance, I had to cancel 3 days of surgery almost a year ago now, because I had the flu, and I was so sick that I couldn't even get out of bed. Every time I stood up, my heart rate went to like the 120s, 130s, and I was still trying to go to work. And my wife was like, "What are you doing? Like, go back to bed." Because I would never want to go into the operative theater. And I said, you're absolutely right. So I canceled my first 3 days of surgery in the whole 10 years I've in career, right? Because we always go to work and do it, even though we don't feel well. And the patients were angry. They were just mad.
Yeah, of course.
And the next time I saw them in the pre-op area, we moved their cases like a week, and I just worked more the next week later into the evening, and went and apologized. And a few of the patients were, I said, I'm very sorry, I was sick, and I remember one of them was just like, well, this is really inconvenient for me. I was like, well, okay. I mean, I understand. I'm sorry. I think I said something effective. Yeah, that's not a very frequent occurrence for me. It's never happened to me before, but I assure you I was very ill, and you did not want me to be your surgeon that day. But I'm here today. I'm happy to take care of you. And those types of things are, that is such a, it's not a great environment to try to be both a surgeon and a human, because I think that many times we're asked through our jobs to not be human and to not have the normal experiences of everybody around us. And so
you're supposed to be always ready for peak performance.
Exactly. And so when we do have a complication, it is even more damaging for people to act like sometimes we don't care, because I think that we care an extensive amount. You're absolutely right. We don't experience the same thing. Like, we're not the ones that end up with the ostomy, or we're not the ones that have the fistula, or the ones that have a quality of life debilitating, hernia recurrence or something like that. But But at the end of the day, I think that we
Yeah, but
experience it.
we suffer.
Yeah, we
Yeah, we
suffer.
suffer a lot.
Really.
Don't understand me wrongly.
Oh, sure.
Is we suffer a lot, but although we suffer and we have this maybe I'm sure you have some of them, and me too. I have patients that I remember for all my life, for
Sure.
the good and the bad reasons, right?
Mostly.
Like people that were very sympathetic and very empathic,
Yes.
that you love that patient, and patients that were huge complications that we went to bed thinking about it and how to do it. And when you have a fistula, when you have someone in the intensive care, and you go there one and another day for weeks or for months, and you are trying to save that patient, of course you live with that. But what I wanted to say is that if you're a pilot, and as you said, if you're a pilot, you're on the cockpit, and someone just tells you that maybe we don't have the best plane for this flight.
Right.
So you just go to the cabin and you say, "Hey, people, this flight is canceled because we are not safe," and that's it.
Correct. Yep.
You can do that, and the system respects your decision.
Yes.
As it should be, of course. But as a surgeon, if you just think that that mesh or that stapler is not the best for the patient because you don't like, I know I'm not putting countries here, but you don't like this stapler because you don't have confidence on that. So I don't think that we should operate on this patient because we don't have the best products and the best materials, the best devices for this case. So we are not operating. I'm sure that your director, your chief, and the administration and everyone is coming. But why? But you're a problem. You're canceling patients, and the patient is very mad on you, and because they don't respect your decision, they don't respect the problem because they are not. They don't have the responsibility. They don't feel it.
Yep, absolutely.
And sometimes, and that's what I want to give as an example, is sometimes we close our eyes to that and say, okay, so many factors, so many complications around me that, okay, I'm doing the case with that mesh, although it's not the best mesh, but okay, I'm doing the case, because everyone is trying to make you operate the patient, whatever it takes.
Right.
So that's why I said that maybe we are selfish at some point. That okay, I do that. I don't like this barb suture, but I just use it because okay, it is what it is. The hospital doesn't give me another one, so I just operate on it. But if there is a complication, you are the one that will always think about maybe that suture. If I didn't do it, I was right. I was thinking about it. I knew that this was going to happen. And that's your problem. No one else cares about that patient.
Well, they can't.
So the system should respect us more.
They never. I don't disagree at all that we carry an uneven load of the burden of the complication, and no matter, even people with their best intentions that are not the surgeon, it's hard to understand. Like, even if they have the best of intentions, you can't understand it till you're there. Even as a resident, you can't understand it until you're there. And so the difference, right? So in a residency, we usually do 1 month rotations, right? So you may feel it as resident. You may have to get up and present it at an M&M conference. You may be ruminating about, I could have done this or this or this. But many times you're not the one seeing the patient weekly and having to go in there every single week and be humbled personally and try to be empathetic, though you're also experiencing a pretty traumatic situation in your own way, and being there for the patient. And sometimes you even feel guilty for you feeling bad because they're the one going through it, not you. There's a whole psychological aspect of a complication that the surgeon has to deal with, the attending surgeon, because of the continued follow-up and the ownership that we have to take longitudinally that other people in the system don't. They get through a case, and many times, for instance, we've had to fight battles over certain types of products for like anesthesia and things. Well, the people within the system, they are looking at a set time frame, right? They look at, well, it doesn't make a difference during the PACU, the time that they're in the post-operative area, right? We're seeing no difference. And some of the point that I've had to make many times is, right, but the benefit is not in that period of time. And so there's going to have to be times that we invest and we do things that don't make sense within the time frame of the people that are having to approve it or work with it, that it may not make sense to them because they're not seeing that. And so then you say, well, realistically, this is when it's making a difference. And to the credit of the people that I've had to have those conversations with, they've been very receptive, and we've been able to do that. But there is a level of having to defend and having to really justify a lot of things beyond just saying, hey, I think this is really the best thing for the patient. And I also understand that there's throughout our system, at least, there's many times where there's waste or is there a true equivalence between two things, and one is just excessively expensive and one is not, right? And the cost of healthcare, at least here, is extremely high. I think that there's a lot of debate on why that is, and I think that many times that's thrown back at surgeons whenever there's a lot of the aspects that we don't have control over, and everybody has to take a little bit of ownership of that. But many times I think it's thrown on us to an inordinate degree, though there are things that we can be cognizant of and improve on, I'm sure. But I believe that we have a situation where there is a discrepancy in ownership of the situation. And if you have everybody around you that many times have a little bit more control of the situation than you might even have as the surgeon, and they aren't as heavily invested, right? They're not the ones going down with the plane like you talk about with the pilot scenario. It's a very different thing. And it's very institution leader dependent. I mean, there's so many factors, and I've had the benefit of practicing under some people that have been very fantastic and really supportive. But not everybody has that experience, and so it makes the practice of surgery, which is stressful in and of itself, even harder. And it also many times those factors bleed over into your ability to go out and review your tape, to go out and try to progress your skill level to the next level when you're down in the trenches and you're taking care of, a deluge of patients coming through the emergency department that all need your care. And maybe there's just not a surgeon around that needs it. And, we're heading into a physician shortage and a surgeon shortage in the United States that realistically, that's probably going to get worse before it gets better. And, but some of the consequences could be potentially pretty rough if we don't really try to think outside the box, so to speak, and find some better solutions. But yeah, I 100% understand what you're saying. That I agree. It's a discrepancy, and the ownership aspect is something that we probably all have room for improvement on.
Yeah, I think so. So I'm just putting my piece in this work.
Sure.
Just trying to give opportunities for practicing. At least if people feel more experienced and feel more prepared to face what medicine is and surgery more, but because in medicine, my wife is an internal medicine doctor, so she treats patients with medication. So if the medication doesn't work, okay, it's a pity, but we can change the medication.
Right.
I'm not doing that. She's not doing a great job.
Right.
But because she will see the podcast.
And then, that'd be a problem.
Yeah. So she's great and she does a great job. But we are doing that with our own hands. I can't blame the medication for the complication. I have to blame my own hands because I didn't do the job as good as I could or should. Of course, that we know with our experience, we can understand that if we are or not guilty for what happened, right?
Absolutely.
Because we know that complications happen. There's a probability of having complications, and that's it. And we have to live with that. But sometimes we know that we were the ones that I could have done more because I was not prepared. I don't know. It's not easy to say this, but that's why it is important for you to see videos, because you feel like you're the god on this, and then you see the video and say, "Oh my God."
That wasn't very good. Yeah. Yeah.
I don't believe I did this, you know.
Oh yeah.
So yeah, it's
Yeah.
interesting.
Yeah. It is.
One of
It
the
is.
great things
And I think
about surgery.
I think we all have seen patient or colleagues that, or just situations where it is the tendency to blame patient factors much more than they probably have an impact on the outcome. I think that we've all heard people say, well, the patient, did this, 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 and this. And then if you look at the case, you're going, well, actually the decision making leading into the surgery or the technical execution of the surgery wasn't good. And that's probably why this happened, And I 100% agree that we have to be able to take reasonable, honest assessment of the situation and take ownership ourselves when things go poorly. Because I think that there is also a very much human psychological aspect where it can be really devastating to you at a personal level.
Yeah.
It to have to sit there and look at that video and go, that's where it messed up. That's why it happened. Yeah. And this person's having this problem because of this. Yeah, I mean, that is a very tough thing to have to accept. And I've lost a lot of sleep in cases that I know that maybe I could have done something different. I've also lost a lot of cases on situations where I'm like, please, why didn't we just, people flushing their drains with tap water, for instance, and me counseling them directly not to do that, and they do it anyway. And you're going, and well, that was a preventable infection. I don't know what I could have done differently to try and really make sure that this was, that this didn't happen. And so there's a level of having to both take ownership and also be able to not just pile all the ownership on you, where there may actually be things outside of your control, like for instance the tools available for you where you are practicing in a very realistic setting. But yeah, no, I think these conversations are very important.
Yeah, one of the things that especially this is a message for younger ones, they have to understand that it's not enough to be technically perfect, mm-hmm. because there are a lot of other factors around surgery on the pre-op or the post-op that can interfere on the surgical outcomes, and you can have infections, you can have complications, not because of you, because you did everything right. Mm-hmm. So it's not only important to be better yourself, but also to let your team, the nurses, everyone, to be better and to educate themselves and to interact with you on doing protocols and having a standardized procedure and of treatment, mm-hmm. So you can have a follow-up of the patient as you want it to be, and not leaving that to other people or other teams or other nurses at the family doctor, whatever. But if you can control that, it's very important. But also, and taking a thing that you said before is that the NBA players are their own product, right?
Yes.
So I think that younger ones should look at themselves as products. Mm-hmm. So it's not. We don't have to follow the same rules and go to the same observerships and same scholarships. Mm-hmm. Every one of us going to vascular surgery, thoracic surgery, trauma, and oncological surgical department. Mm-hmm. Why? Why don't we go to gastroenterology for a scholarship or observership? Or why don't we go to radiology? Why don't we go to another special like gynecology to be able to learn different things? So if we are exactly the same residents when we finish residency, how can we be different on the market? So maybe some of us can go a little bit to management and learn about management, do a postgraduate course on management, or some of us can go to practice and education, and some dedicate themselves a little bit more to bariatric surgery or to abdominal wall surgery or colorectal surgery. So when we finish residency, we're not just the same, at the national level, we are all the same, and some of them are a little bit better or worse, but we are just the same product. So it's important to plan ahead. What do you want to do, and how you can address the market as a different surgeon from the others. Although in Portugal, most of our practice is public, so that's also a problem because planning is not happening. If you're talking about a private practice, I believe that they plan ahead, like they need 2 breast surgeons, 2 colorectal, 3 bariatrics.
Yes.
And because hernia will increase a lot, so we'll have more hernia surgeons.
Right.
That's fine. In the public system, mostly, I would say you have, in Portugal at least, you have as many surgeons as you need to cover the emergency. So you need 3 surgeons per day, 24 hours shift for the emergency. So you have 3 plus 7 days a week. You need X surgeons on this department.
Right.
And then you see that the operating room is low, the volume is low, the time for educating and training is low, but everything is okay to have the minimum people for as it's written in the law, the regulations, to have these surgeons for this specific hospital. So it's difficult on the public to have this planning. We don't have it. If I was chief of department, I would be very interested in understanding. Although general surgery residency is general, so we should be the best general surgeon as we can. But we should start, even during residency, start to planning ahead, because this one is retiring in 2 years, this one is retiring in 5 years, this one is going somewhere. So we need this and this and this. So planning ahead would be very important for people also to be able to follow a path, because they know that they are getting this job in some years. So I should dedicate myself. I should put effort and investment on this area because I'm getting this job in the future.
Right.
Otherwise, it's just, okay, I'm just here doing my residency because I don't know where I will end up working. I don't know my area of surgery. I don't know anything. So I'm just doing residency. So the system is there are a lot of factors to get better on the system. I don't know if it's possible to do it someday, but step by step, maybe it's possible to get better.
Like you said, it's a very complex problem. But one thing you said that really resonates with me is that it is really hard to innovate. It's really hard to move things forward, and it's really hard to educate whenever you are bare minimum staffed and you're trying to just keep up. If every day you go to work, you feel like you walk in and you're already way behind and your hair's on fire, it's really hard to do anything for your own personal or professional growth, or for the growth of those that were entrusted in training, and so it's a difficulty because there's the financial pressures that the people that are making the decisions are feeling. I'm sure that there are aspects of it that I don't understand, but I can tell you what it feels like from being in the fight, and that is that sometimes it feels like you are being pulled in so many directions that it's really hard to adequately accomplish what we're trying to accomplish. But honestly, it's people like you that are doing all the work with the training and the surgical education and the modeling and everything that's really going to kind of hopefully take us to the next level. So we just really thank you for all the work that you do.
Yeah, thank you so much.
Well, as we wrap up towards the end of a podcast, I always offer people their opportunity to give their hernia hot take, their popular opinion, unpopular opinion, or otherwise regarding hernia surgery. So, Mario, this is your chance for your hernia hot take.
Yeah, I mean, I think that, as I said at the beginning, I think that we're living a great moment in hernia surgery, abdominal wall, and I would give, like, if you want, if you're a resident and if you want to have, if you want to be an abdominal surgeon, I would say that you should take care a lot of anatomy, and you shouldn't see the patient as a hernia, but a hernia on a patient, and know a lot about materials, medical devices that can help you do the case the best way possible, and especially pre-optimize your patient before going to surgery. I would say this would be the counseling that I would give to someone that wants to start as an abdominal surgeon. Maybe you can tell me, okay, but that's the same for any other surgery. If you're talking about colorectal surgery, you should take care about anatomy, about the patient, about the pre-optimization, and about the medical devices. Yeah, but especially in abdominal wall, is that, and what I think is the one of the greatest things about abdominal wall is that you need to have a lot of plans. So you have to have plan A, B, C, D, whatever, because although you have a look at the CT scan and you can evaluate all the hernias, you can evaluate the abdominal wall, but when you get into it, you see that the muscle at the end is not the muscle that I thought the patient had, or because you did a CT scan 3 months ago and then you have pneumoperitoneum, you have a BTA, you have any other thing that happened on the pathway, and now it's different. And you're thinking about doing a procedure, and then you go there and you have a scar, you don't have peritoneum, you can do a TAPP as you wanted to, so you have to go to a retromuscular space procedure, or you have to do a TAR, or you have, so it's very that's what I love about abdominal wall. It's because it makes you think, not planning before the surgery, but also thinking about the surgery all the time, thinking how to do this, how to change the plan, how to bring this fascia to this side and the peritoneum to the other side, and sometimes trying to get a lot of different procedures into that procedure, the procedure that you really need to that patient, and that's very interesting, and especially because I like physics. So thinking about the forces that come into the abdominal wall and how all of these things work together, it's very, very, very interesting. So I would say that I'm in love with abdominal wall surgery. And I think that we are living a really great moment in abdominal wall in the world right now. So I feel a privilege, immense privilege, to be an abdominal surgeon in 2026.
Well, I think your passion is very evident. I think we all stand to benefit from that. So again, thank you for what you do, and again, thank you for coming on the podcast. I've had a great time talking with you and getting to know you.
Me too. It was a great pleasure and a great time to talk with you and to meet you. I hope that we can meet in Porto in June 2026 for the European Hernia Society Congress. And also thank you for doing this podcast, because I think that it can be a great message for younger colleagues that just listen to you, listen to me, listen to all the different people that you bring to the podcast. And maybe we can serve as, I wouldn't like to say it, but as an example for them to follow and to see their lives. If they are lost on the process, they can, okay, I'm just doing this and that, or I just heard this or that. So just if we can, that's what I said at the beginning. Create opportunities, so create opportunities for everyone to be the best they can.
Yeah,
that's the goal.
If just one person can hear something that's been discussed and feel like they may not be alone in their struggles or their experience, I think that I would consider that a success. So, well, thank you so much again for coming on. That'll wrap up another episode here of the Hernia Gods Podcast. I'm your mere mortal host, Luke Elms, signing off, and thank you so much, Mario.
Thank you.